transmission, the harder it is to protect people. And if you look at international data collected by Adelina Comas-Herrera, there's a straight line correlation between high community transmission and high deaths, both in care homes and in the community. So the real key to this is minimizing community transmission right from the beginning. Once you lose control, then all other measures that you can suggest are going to have a limited impact.
And in your view, is there any value or added value in restricting movement of staff between settings if you're not restricting the staff's contact with the community?
It's almost impossible to, unless you lock people up, and that's just not a practical option, isn't it? People have to go home to their families, their children were at school, schools were like petri dishes. Some people, as you've heard already, did move and live in care settings. In home care, you can't easily do that, with the exception of live-in care, which is an established way of doing things. So in that setting, the care worker lives 24/7 in the home of the person that they're supporting, and that is very popular for people who have more advanced care needs and would rather not go into a care home.
Thank you. Can we move on to a different topic, please? If I could ask for page 91, paragraph 381, please, to be put up on screen. You say here that the government's engagement and consultation with the home care sector during the pandemic was often inadequate, poorly timed, and demonstrated limited understanding of operational realities. While some improvement occurred as the crisis progressed, initial communication channels proved insufficient for the scale and urgency of the challenges faced. Is that correct?
It is correct.
You say in your statement that you were involved in at least 12 groups, which considered a various number of different topics. The inquiry heard evidence from Professor Vic Rayner about those groups to some extent acting in silos. Is that an experience that you share, or is there anything else that you would like to tell us about in terms of how those groups worked and whether you found them helpful forums?
They were helpful, there is no question about that. And we are grateful to the Department of Health and Social Care and the director who became the Director General later, Ros Roughton, for trying to involve us all. I mentioned the Care Provider Alliance. So this is a coalition of the 10 care associations in England. Prior to the pandemic, we met about once a month. But when that lockdown first happened, we realised it was going to be bad. So we decided that we would meet every day. And we did that all the way through the pandemic, and now meeting once a week. But there were just not enough of us to attend every single meeting. So we split up responsibilities and then regrouped every day to share intelligence. And then we tried, where possible, to present a united front to influence. Between us, the Care Provider Alliance, we cover 95% of care providers in all settings.
I think one of the forums that you and Professor Rayner both say was particularly helpful was the task force that was set up and led by, I think, Mr. Pearson. That task force had a number of subgroups, is that right, looking at specific issues, and at the end of that process, reports were produced. Were the recommendations in those reports implemented so far as you're aware?
Certainly in the workforce subgroup that we were involved in, along with Vic Rayner, none of the recommendations made were implemented.
Are you able to help us as to why they weren't implemented and what could be changed in future to ensure that doesn't arise again?
I think it probably reveals a general problem with social care, that the way the whole sector is structured and governed allows people to pass the buck. So ministers will say, oh, sorry, it's the statutory responsibility of local authorities to do X, Y, or Z. So every time anything difficult comes up and we challenge ministers, local authorities get a letter telling them to do X, Y, and Z. If you talk to local authorities, they'll say, we're really sorry, we haven't got enough money because central government doesn't give us enough. That's also true. So there isn't anybody taking proper accountability, and it's very easy for people to be ignored in that kind of environment because it's always somebody else's fault.
You say in your statement that some of the key decisions were made without meaningful input from the home care sector. And an example you give is in relation to the February and March PPE guidance. Could you clarify, please? We looked at some correspondence with Professor Rayner where draft guidance was sent to her the day before for her comments. Were you copied into such correspondence? And so are you saying that you didn't have any meaningful input, or were you not included at all?
No, we were included, and if you look at that chain of correspondence, you can see that we did comment on the draft, but the comments that we made were not incorporated. So there were some inconsistencies and some confusion that were still there and when they published the final version. But quite often the guidance, the draft, would come out at quite a late stage of production with a very tight timeline. And unfortunately, they're still doing this. So a couple of weeks ago, we received a 160-page document of pandemic preparedness guidance, and were given about 5 or 6 working days with no notice to go through it. And that kind of thing is very difficult because even if you have comments, they won't get incorporated because there's some deadline. So what we want to see in future is much earlier engagement. And with Public Health England, later in the pandemic, a person appeared who was willing to engage with us one-to-one and really understood our sector, and things massively improved after that.
Thank you. On this topic, I just want to ask 2 more questions. So firstly, you say that the government relied on the on ADAS, is that right?
ADAS, the Association of Directors of Adult Social Services.
To disseminate communications and guidance throughout the pandemic. You say that they only really had the contact details of those providers that they had contracts with. But you also say in your statement that the majority of home care providers were receiving commissions from local authorities. So, first of all, do you know what the reach was? Putting the personal assistance to one side, do you know what the reach was? And do you think that there's any better way of reaching out to a larger part of the sector in future? So
independent industry analysts' data show that about 80% of home care services are purchased by either local authorities or the NHS, and about 21% are purchased privately. So it was very noticeable in some areas that councils didn't have a good idea of which providers were there. But the Care Quality Commission has a register, and their data that's available online is you can filter it by local authority area, by parliamentary constituency, by lots of different means. So there wasn't really a reason for them not to know. It's just that they didn't have a working relationship. And I think in future that it did improve during the pandemic, because later on, with the vaccination rollout, in home care, councils were told that they had to organise the vaccination programme for home care, and it was honestly very shambolic. We pushed and pushed to get the National Booking Service opened, which was resisted, but eventually they did agree, and that made life very much easier.
Thank you. And can I ask you about data and research, please? We heard from Professor Shawcross about the difficulties in collating data from domiciliary care, and she identified it as being a research gap. Could you help us as to what the current position is with regard to digital transformation of the sector? And whether, from your perspective, there are certain types of data that you think are urgently needed to understand the sector better? And do you have any suggestions in how the data infrastructure can be improved?
So prior to the pandemic, about 40% of home care providers had digital social care records. As we stand today, we're at about 80%. Most of the focus of digital support in the pandemic, though, was to care homes. Home care providers were left to their own devices, and being an entrepreneurial and innovative bunch, did all sorts of changes to make remote working. Obviously, you can't remote work and deliver domiciliary care, but in terms of office functions, training, support, some of our members created their own well-being apps and so on to try to find ways to support the remote working workforce. So I think the data collection in the pandemic did improve gradually. The problem we came up against was that suddenly everybody was asking for data. So central government wanted data, local authorities wanted data, and the poor providers were trying to keep the show on the road. So it created a huge administrative burden. So we spent a lot of time trying to encourage to minimize that problem. Where we are now, there is much better data than we had before. But the big flaw, as far as I'm concerned, is that they are not sharing that openly with the public and not with the providers that are submitting it. And actually, access to that data would help everybody. Other countries do it differently. So, for example, in New Zealand, the providers have to submit data using something called a minimum data set resident assessment instrument. That data is useful to them in delivering their services, but when it moves up, it is aggregated and anonymized, and then government, whoever regulators can access it and see what's happening. That's where we ultimately need to move to, but we're quite a long way from that at the moment.
Thank you. You set out in quite a bit of detail in your statement the pre-existing challenges that the sector faced going into the pandemic. I won't go into all of those. They are set out in detail in your statement. But can I just ask, in terms of the financial instability that you describe, is it fair to summarise it like this, that pre-pandemic, on average, councils are paying less than the minimum price for home care services. And most of home care services were paid for on a 0 hours basis. And the way it was procured and commissioned meant that providers were effectively encouraged to race to the bottom on price to win packages of work. Payments for care were also delivered in arrears. How do you say that combination of factors impacted on the ability of the sector to be able to respond to the pandemic?
It has a massive impact, and I think we're the only part of the entire health and care sector, and possibly the only part of the entire economy, where workers are paid by the minute. It's honestly a national disgrace. And if the person that you're supporting has to go into hospital, the councils and the NHS stop paying the provider. So this creates a working environment with insecure income, unpredictable and insufficient, because the rules are that you have to be paid for all of your working time. So that is the visits to the people that you're supporting, and also travel from one person to another. And the amount that's paid isn't enough to cover all the costs. And the people that suffer are those drawing on services and the care workers.
Thank you. I'm sorry, I didn't mean to interrupt. I think we have limited time, so I'm trying to make sure we get through everything. But is it right that one of the things that you were highlighting to government during the pandemic was that there were increased costs for providers associated with the pandemic? So, for example, the cost of PPE, the costs of having to pay for staff who were working extra hours or who were isolating. But also there was a reduction in the income of the providers, and you say that combined led to a 35 to 40% hit to most home care businesses. How did that affect their ability to absorb unexpected costs during the pandemic?
Well, obviously, it made it very difficult. We commissioned some work early on to come up with those numbers that were based on evidence, and we submitted a paper to the Department of Health and Social Care, which went to the Treasury, and we were later told that that was instrumental in encouraging the Treasury to release money to local authorities. So they issued 2 tranches, 1.6 billion on the 19th of March and another 1.6 billion in April. And in the meantime, we worked closely with the Local Government Association and the Association of Directors of Adult Social Services to make some suggestions, recommendations for how councils could help home care providers. And one of the suggestions we made was that they switched from paying in arrears on actual delivery to paying in advance on planned. And many of them did. And honestly, that saved the sector because it helped to maintain some financial resilience. Unfortunately, after the pandemic, they've all gone back to their ways of buying it by the minute at low rates.
Thank you. And can I ask you specifically about the Infection Control Fund, which you say was inconsistently distributed by local authorities during the pandemic? How do you think that process can be improved? And do you think it was right to give local authorities the power to decide how it should be distributed and to whom?
The first tranche was 75% for care homes, and the remaining 25%, it was left to the discretion of local authorities about what to do with it. Some local authorities, I mentioned Hertfordshire, they basically just decided to get the money out to everybody ASAP. That was a better way of doing it because everybody had different ways and had different needs. So, for example, if you were lucky enough not to have any infections, you didn't need to use that money for isolation, but you might have wanted to use it for other things. So, for example, some of the care homes used it to create visiting pods in gardens and all kinds of things. So giving providers the flexibility is much the better way.
Thank you. Could I ask you about PPE, please? Could you just briefly give us some examples of the key issues that your members and the sector more widely had in accessing PPE, and in particular with the portal, please?
So prior to the pandemic, home care workers typically use aprons and gloves. Do not typically use masks except in very specific circumstances if you've got a person who is generating aerosol, if there's a risk of aerosol exposure.
So just pausing there, you highlight that in your statement. Why is that significant?
Because nobody routinely ordered masks and weren't familiar with the different types of mask and what they were used for. Providers normally have business as usual suppliers, so they will do a PPE order, have it routine, and pay for it, and then the suppliers deliver just in time. Many providers don't have much space. The home care offices are usually pretty small rooms in industrial estates, and that's because there is no money in the sector. So the suggestion that Matt Hancock made about having 5 years of PPE supply or something simply isn't a practical proposition.
I think it was a month.
A month. But even that...
Is that practical?
Even a week is a lot. But it works much better. That the PPE portal, which we'd suggested they did, was a really good idea because it allows you to procure in bulk, which enables good negotiation of prices. So many of our members are very small providers, and the problem that they have is no negotiating power. Some of our larger providers did much better because they were able to buy at prices that were more reasonable, but especially the small ones, the prices were really raised because it was so difficult. So it was accessing it. The business as usual orders that people had made were redirected to the NHS for whatever reason. It doesn't matter. The fact is they didn't have them. And it was difficult to know what PPE to use. The first set of guidance that came out, as you know, said that community transmission wasn't likely and they didn't need to use PPE. Nobody actually believed them. So,
sorry to cut across you, but is it also right that there was some confusion about the specifications with regard to masks, especially where the guidance appeared to be inconsistent, either in itself or with local guidance that was produced?
Yes.
And could I just move you on, please, to deaths and end of life? Is it right that you did see a rapid rise in deaths in the sector? However, those were consistent with levels in the community. But what you do say is that that was consistent with more people dying at home rather than in hospital. And did you see any evidence from your surveys and members that the quality of end-of-life care suffered as a result of that?
In general, it was difficult for people to access healthcare services, and I would say that the people with professional home care workers possibly did better because they had people advocating for them and fighting on their behalf. People that were being supported by unpaid family carers struggled much more, and I think there was a lot of fear and anxiety, not knowing the right thing to do and not being able to easily find people to talk to.
Thank you. And before I ask you finally about recommendations, can I ask you this, please? You say in your statement that throughout the pandemic you witnessed the very best of human dedication in the sector. Could you provide some examples, please, of positive things that you saw and good practice that you would like to share?
I think, first of all, I just want to put on record our deepest sympathy to the bereaved families. I think they've been remarkable in their bravery at coming here and engaging with the inquiry. And I'd also want to thank care workers because they were the only people often that were going out and about. The GPs were remote working, the district nurses were remote working, the housing managers were remote working, the CQC inspectors. So they were incredibly brave, and it was difficult early on to get them so-called key worker status. So, for example, they were being stopped by the police, they were being abused by members of the public who thought that they were breaching lockdown rules, but they were just doing their jobs, and they were the eyes and ears for everybody else in the system because they were the only ones going in. So,
thank you. And finally, apart from the ones that we've covered, could you please give us your top recommendation that you would make?
So I think it would be useful to have some standing high-level social care committee for the pandemic because we need social care expertise at all levels of operational command, science, and policy development, and guaranteeing equal access to PPE, testing, funding, sick pay, vaccination. All of those things, home care was at the end of the queue, but the people that we were supporting had just as much risk, as I explained.
Thank you.
Yeah.
Thank you, Dr. Townsend. And my lady, those are all my questions. I think there are some questions from the call participants.
Thank you. Ms Morris, I think you're going first.
Thank you, my lady. Good morning, Dr. Townsend. I asked questions on behalf of the COVID bereaved Families for Justice, and thank you for your kind words a moment ago. You also touched a moment ago on the issue of remote working, and I wanted to ask you some questions, first of all, on the topic of access to services. You said in your statement that access to certain professionals during the pandemic became quite difficult, and that your members raised concerns about the quality of some of the remote assessments by social workers, and GPs are two examples that you give, particularly where those with care needs had problems with communication or, for example, those living with dementia. You gave examples of where packages of care were often inadequate because the carers had yet to meet the individuals, and providers were asked to start providing care and support without knowing, for example, whether the individual was able to move, mobilise or communicate. And there are examples that you gave of care plans and time assessments being inaccurate. So was there a concern by your members that services had, if you like, stepped back from those receiving domiciliary care during the pandemic?
Sorry,
Was there a concern that some services sort of stepped back?
Yes.
Particularly in where people were receiving care in their home?
Yes, we were very concerned about the social work assessments being done remotely, because you really need to see somebody's environment and sit down and talk with them. And we saw a big waiting list develop of over 500,000 people waiting for assessment. And until those assessments are done, care isn't available. So many people were struggling when they needed support and weren't able to get it. And then when the care workers went in, it wouldn't matter that the assessment was inaccurate if care workers were given more autonomy to make decisions about what did need to be done, which is more possible when you're supporting people buying their own care because you're having a conversation with them. They are the commissioners. But in many cases, if it's a state-funded client, that care worker has to go up through, I don't know, could be 8 different levels in a council sometimes to get permission to change the care package. So that isn't ideal. And one of the changes we are pushing for in general is the care workers know people better than anyone else. They're in and out of their houses multiple times a day. Please trust them more.
So what are some of the impacts that were being observed during the pandemic on those receiving care?
Well, many people became very isolated, even the ones who received professional care, who arguably were more fortunate than those who didn't. But it could be a long day waiting by yourself without connection with family. As time went on, more providers were enabling the people that they supported to connect digitally with their loved ones, and that made a big difference.
Thank you. The next topic I'd like to ask you about, please, is about easements. And you discussed in your statement the impact of Care Act easements and noted that some local authorities seemed to relax Care Act duties even where the formal easements hadn't been triggered. And you expressed some concern about the impact on people receiving care because members reported instances where some essential support was reduced or withdrawn. So can you just expand on that a little bit? Kind of what were the concerns? What were the examples of support being withdrawn? And did they, in your view, sort of reduce the protections available to those with Care Act needs?
Yes, so we suspect that the Care Act easements, they didn't use the formal legal process in many cases. The first inkling that we got that this was happening was in the middle of March. 11th of March, we received an email from one of our members saying that they'd been approached by one of the local authorities saying that they needed to reduce the care packages in domiciliary care in order to free up capacity for hospital discharge. And they said in this email, oh, by the way, they won't have COVID-19, which nobody, nobody believed that. So that process to reduce the care available, some of that was also because families were at home, so people were remote working and were furloughed. So they might have taken risk factors like that into account. But in general, we were concerned that people that needed support were having it taken away or reduced.
Staying with easements, moving beyond the pandemic, is there concerns that relaxation or easements set any precedent beyond the pandemic?
Well, all the time, because many local authorities are very short of money, they are constantly looking for ways of reducing the care available. And it is an ongoing issue of assessing, reassessing, cutting care, reducing care. And many people only qualify for state-funded home care in the first place because they've got quite high levels of need. So we are very concerned, and if that care reduces, then people just end up in hospital. That's what happens, which is puts pressure on the whole system, and we end up seeing ambulance queues, people not being able to be admitted because there aren't beds, the waiting lists for treatment reaching 7.5 million. A lot of that is because the entire system is not being resourced in the most cost-effective manner.
So are you concerned this is an ongoing issue?
Yes.
Thank you. My third and final topic is around data, and you've already touched on some of the concerns around unregulated care workers in your evidence this morning, because you've noted that the CQC holds only the only comprehensive central register of regulated care providers. You've said in your evidence this morning that you think about 20% of the workforce is unregulated within domiciliary care.
It's over 120,000 according to Skills for Care data.
Okay, thank you. And you said this morning as well that unregulated personal assistants, for example, are, quote, off everyone's radar. So there is, in your evidence, there is a significant gap in understanding of this particular part, an important part of the workforce. Okay, what is the impact, in your view, of not being able to reach that full sector, both of those receiving care and those providing that care during the pandemic? You've given two examples, I think, PPE and its distribution out to those who need it, and vaccination. But are there others?
Well, testing would have been another one. But just in general, the support for those care workers as well, because often you will encounter quite challenging situations, and at least in a regulated agency, the care workers have got someone that they can ask for support, or they can go to a Care Quality Commission person, but the unregulated care workforce doesn't have anyone.
You mentioned training as well this morning. Is that an additional sort of gap for those in the unregulated
There's no requirement for mandatory training. The responsibility for that is left to the person drawing on care. But the research that we've conducted suggests that many members of the public don't understand that there is a difference between a regulated managed service and unregulated care. Like, anyone in this room could walk out here this morning, put an advert up and set up shop as an unregulated carer. No questions asked.
Thank you. Do you have any experience of whether the CQC register tends to be accurate of the regulated providers and whether it's regularly updated?
Yes, it is very accurate, and it is a criminal offence to operate a managed regulated service without registering with the CQC. So if they find that that is going on, they will investigate. We feel that they don't investigate enough, but when they do, they have brought some prosecutions in some cases.
That's going to be my next question. Do you have any knowledge of whether and to what extent there are providers who should be registered with the CQC but are still operating despite not having registration?
We think that there are quite a number. You can report them when you come across them. It isn't always that there are organisations known as introductory agencies. They're like employment agencies, and they're a bit like an Uber platform. So if a citizen wants care, they register on that platform. If an individual care worker wants work, they register on the platform, and then the platform connects them. And some of the introductory agencies spend time monitoring and managing the care, which technically they're not supposed to do. They're only supposed to do the introduction. So it's not that the care is necessarily unsafe. It's just that if the regulation is there to create a level playing field, that's what it should do. There shouldn't be a group of people over here allowed to get on and do whatever they want, and another lot of people over here having very stringent regulatory requirements imposed.
Understood, thank you. Just in my final questions, sort of allowing you a chance to expand further, can you explain the impact of the limited understanding of the sector and that the lack of understanding about the number and identity of providers had on central and local governments' communication and coordination within the sector during the pandemic?
Well, I think in terms of trying to find out how many providers there are, what their needs are, what the risks are to the people that they're supporting, was hugely difficult. Obviously, with the CQC registered organisations, it's much more straightforward. And the CQC has got rights to any information it requests. But for everybody else, it's very difficult. We think that in the devolved administrations, there are registers of professional care workers. We think that everybody should do what Scotland is doing and add the unregulated personal assistance to that register. Of the devolved administrations, we feel that Northern Ireland has done it the best. They have focused their register on competence and conduct, not qualifications. And I think that is the most pragmatic approach for our sector.
Thank you. Those are my questions. Thank you, Dr. Townsend. Thank you, my lady.
Thank you, Ms Morris. And Mr Straw.
My lady, my microphone doesn't seem to be working. It's on now. Thank you. Dr. Townsend, I represent John's Campaign, Patients Association and Care Rights UK. Firstly, you note that often the only professionals who would visit homes were care workers, but there was fear about infection being passed on if care workers visited in multiple homes. Should more have been done to ensure that a person's essential or family carer could visit, given that they may not pose the same risk in terms of multi-contact infection risk?
Yes, I think so. And later we had bubbles, didn't we, which made that process easier. That would have been good to have had from the beginning.
Thank you. At paragraph 144, you note that the majority of excess deaths at home were not directly ascribed to COVID, but to other causes such as dementia. And elsewhere, you explain in detail the severe impact that isolation had on those with dementia and others like them. Are there changes that should have been made to reduce isolation in the pandemic?
I think that we've learnt from many countries, not just our own, that the risk to everybody's mental health needs to go up the list of priorities. The focus was very much on infection prevention and control, and the well-being and ability for families to see their loved ones was sacrificed. I think in future it would be better to have a much more nuanced approach to that, recognising the importance, the vital importance for health of human contact with people that you know and love.
And can you give any recommendations on how that might be done? For example, would it be helpful if there was government guidance which described those potential adverse harms and encouraged risk assessments which properly took into account those adverse harms?
I think government guidance is obviously helpful because providers, especially the regulated providers, they have to demonstrate that they are meeting government guidelines and other regulatory requirements. So it does help a lot to have some ground rules. Everyone gets very nervous about making things up themselves because the Care Quality Commission or whoever might come along and say no. So I think that would be a good idea. And I think if the visitors are consistent, what is the risk? And if people have got mental capacity, they should be allowed, I think, to judge that risk for themselves. Later on, when people had vaccination, triple vaccination, the risks went right down.
When you say if visitors are consistent, is an example someone who has an essential carer who's their single and only essential carer,
Yes.
and that's the only person they're really visiting?
Yes, like if it, for example, it was a son or a daughter that always went to visit mum, why would you not allow them to carry on? Later those arrangements were possible, but early on they weren't.
Thank you. And final area, please, is data. You note in your witness statement significant gaps in data collection and monitoring of deaths at home. And you also explained that at the time of the pandemic, home care providers were not required to report a death unless it may have been the result of regulated activity or how it was provided. Is it your understanding that this is likely to have meant that the number of both COVID-19 deaths and also non-COVID deaths would have been underreported?
The reporting of deaths is governed by Regulation 16 of the Health and Social Care Act 2008, which was revised in 2014. So in a care home, everybody that dies has to be notified to the Care Quality Commission. In home care, it's only, so for example, if Mr. Jones has a heart attack at 4 o'clock in the morning, his wife calls an ambulance, he gets taken to hospital and dies there. That does not have to be reported to the Care Quality Commission by a home care provider. If, on the other hand, the home care worker turns up, Mr. Jones is having a heart attack there and then, they call an ambulance, do CPR, and he subsequently dies, you would have to report that because you were physically there as a home care worker. The other time when you have to report is if there's any possibility that the person died as a result of you carrying out the regulated activity. So an example might be you accidentally drop someone out of a hoist or something like that. It's vanishingly rare that that kind of thing happens, but that is the rule.
Okay, I'll leave it there. Thank you very much.
Thank you very much indeed, Mr. Straw. Thank you very much indeed, Dr. Townsend. You've been very helpful and a very powerful advocate for the sector you represent. So thank you. I'm sure we should be seeing you again during the course of the inquiry. Thank you very much. I shall adjourn now for a 15-minute break, so I shall return at 5 to 12, or just over 15-minute break. Thank you.
my lady, may I call Sir Sajid Javid?
Thank you, Ms Cecil.
I do solemnly, sincerely and truly declare and affirm that the evidence I shall give shall be the truth, the whole truth, and nothing but the truth.
So Sajid, I think the last time you came, I was chairing the hearing remotely. It's nothing personal, I assure you.
No, it's lovely to see you.
Sir Sajid, thank you for attending and assisting the inquiry today. As my lady's noted, you've provided evidence before now on a number of occasions, and that's touched upon some of the issues that we're dealing with today. But what I do not want to do is go over old ground effectively. So if I can just take you briefly, therefore, through your professional background and specifically your role in respect of the adult social care sector. On the 26th of June of 2021, you were appointed as Secretary of State in the Department of Health and Social Care, is that right?
Yes.
Immediately prior to that, you were a backbencher?
Yes.
Following earlier appointments in government?
Yes.
And the time period that we're dealing with or concerned with today is from the end of June of 2021 until the end of the following June in 2022.
Yep.
Similarly, we've discussed previously in your evidence the composition and structure of the Department for Health and Social Care, how it worked, and the various interactions that took place. And you've helpfully set those out within your witness statement for this module, so I'm not proposing to go over those, but I want to deal, if I may, instead, with your overarching thoughts on the adult social care system. And in your statement, at paragraph 57, you describe that as being stretched financially and understaffed and in need of significant reform on a national level to improve quality of care and increase in service need. Just want to ask you, please, if you can just expand upon that a little bit in relation to that pandemic period and specifically the pressures that were faced by the sector at that time.
Yeah, thank you. And if I may, my lady, may I just begin by thanking you and the inquiry team for the vital work that you're doing. And I deeply respect the importance of all this process and all that you're doing. And I'm grateful for this opportunity to contribute and hopefully contribute to lessons learned. So thank you for that. But turning to the first question, in fact, when you referred to my experience a moment ago, I think what might also be relevant for social care, adult social care, is my time also as a local government Secretary of State in then what was called the Department for Communities and Local Government, because you'll know from perhaps other evidence the role that department also plays in the social care sector.
Of course, we're going to turn to some of those aspects later.
Right, and so that's where my sort of direct experience, sort of more direct, I guess, as a government minister really began. And it was clear to me from then on that even before the pandemic, the social care sector as a whole was under an enormous amount of pressure, enormous amount of challenge, especially around issues around funding, because unlike the NHS, the social care sector, the funding is in different sources, central, local government, private providers. Is much more fragmented, is locally run by the relevant sort of local councils oversee it rather than central government. And so all of that, whilst there can be good reasons for the sort of fragmentation and things, and when the system was sort of first set up, so to speak, what I saw was a system that was already before the pandemic under severe stress, especially around funding and especially around workforce as well. And then when I became health secretary, obviously it was in the sort of latter half of the pandemic, so to speak. There were obviously significant challenges you've heard evidence on in the sort of the first part, if I can call it that, of the pandemic. By the time I had become Secretary of State, I think some of the most immediate sort of challenges in the sectors that were in a better place because of the vaccines, for example, more PPE and better IPC and things. But there, of course, there were still challenges, particularly around still issues around funding, around workforce, and other challenges.
Thank you, and we're going to move through some of those. But if I may pick up on one of the things that you've just mentioned, and that's the fragmentation of the sector. And the fact that obviously you have different government departments, you have local authority, and then you have the sector itself, which is comprised of public, non-profit and private sector organisations. We've heard from your predecessor, Mr. Hancock, that levers or the lack of policy levers was a specific issue of challenge within the pandemic from his perspective. Obviously, that was earlier in the pandemic.
Yeah.
But is that something that you would agree with in terms of that central departmental governmental role?
Yeah, the general point I would agree with, but what I would point out is that probably one of the key reasons there's a lack of sort of central levers for central government is because of the way the system is set up in terms of local government control, private providers, combination of funding, and all that. And if central government were to have more levers, none of this is without trade-offs. There's always trade-offs I found in government in making any decision, and often I think they're not sort of fully appreciated, that if you move in one direction, you might lose some valued aspects that you had before. So, for example, having local authorities in general, sort of certainly outside the pandemic, overseeing social care, whether it's for working age adults or older people, meant that it would be closer to the community. Your local needs would be met. Different parts of the country, there will be different ways to provide care and different types of settings. There might be other sort of local issues that could be more easily addressed. So I think first of all there is this trade-off. But that said, I think already it's clear from the pandemic that it's certainly at the start of the pandemic and throughout, it would have been helpful had there been sort of more levers and things done. And that is actually one of the reasons when social care was a sector I did spend a lot of time, and I thought about it a lot, not just the immediate sort of pandemic needs, but also sort of more medium to longer term. How can we improve this system that I had already had some contact with in my previous government roles? And that was one of the reasons I introduced the white paper on adult social care reform in 2021. And I point to that because it did include a number of what I would call levers that I think would be very helpful to future governments, not just in pandemic situations, but in just generally in helping the sector. So, for example, better access for central government to data and information, including anonymized data, and also better having standard sort of information standards, more digitization of that data, and also other measures, again, which were central, but I think gave more levers, given the CQC, for example, more levers to in terms of its ability to assess local authorities in their performance of doing their statutory duty in terms of social care, and also allowing central government to make direct payments to providers in the future, and also giving a general power of direction to a Secretary of State in that sector, whether it's in a crisis or a localised emergency.
Thank you. And you provided that white paper to the inquiry, and the inquiry has that. If I can turn then to discuss another topic, it's that of hospital discharge. Of course, the pressures were not quite so acute at the point when you came into the position, but just touching on the discharge to assess model and delayed discharge. You've explained that the issues are complex, and you suggest that there needs to be some thinking about solutions in that respect. And one solution that you posit is the role of what was then DLUC, obviously now renamed, and cross local authority working via a central system. Can you just expand on that very briefly?
Yeah, sorry, can you ask that latter part of the question again?
Of course, really, it's how that would work in practice. So what I'm interested in is you suggest that one potential solution is effectively cross-local authority working via a centralised system in conjunction with what was then, and staying with the pandemic offices as they were, the Department for Levelling Up Housing and Communities.
Are you, and just to make sure I understand, are you talking particularly about the discharge to assess?
Yes.
Okay. Yeah, so in fact, again, in my experience in that department, the local government department, one thing I remember from that time, obviously pre-pandemic, even at that time, delayed discharge, the whole issue of delayed discharge, which was one of the reasons for discharge to assess, was a big issue then. The then Secretary of State for Health was Jeremy Hunt. I remember a number of meetings with him about what could my department, or more accurately, I guess, local government do to help with assessments of people that were medically able to leave hospital, but the sort of assessment of any further support or care had not been made. So it's something I was sort of the concept of something I was quite sort of familiar with. Also, when I came into the health department, that sort of policy in terms of more support, certainly more financing for it, direct financing to the NHS, had already started, and so I sort of came in and inherited this sort of new approach, and I continued with it. Because I saw it as an important part of, first of all, certainly freeing up as many beds as possible in the NHS for urgent medical needs. Also, I thought it would reduce the sort of the number of transfer delays, because you would also find people that they knew they didn't need to be in hospital, they were eager to get out, and I think that having this funding and support would make that quicker. And I think it was also a more what I'd call like a person-centered approach. Maybe it meant that you want someone sort of out of the immediate environs of a hospital and in a sort of community setting. Maybe there was some time to sort of assess more sort of carefully, take a little bit more time to work out what sort of longer term support they need. I felt that, in terms, more directly to your particular question, is that I felt that that it was an area where the more cooperation there was between local government and the NHS, in particular, the NHS obviously had the sort of purse string, so to speak, on the funding of discharge to assess. The more focused it could be on the needs of that particular individual. And I felt that to do that, going forward, it meant the more data the NHS had, more data and information there was on that individual, the more data and information that there was on the local setting and what support was available, that would all help to lead to a quicker assessment, but a more appropriate assessment.
Thank you. And then just also picking up on the actual discharges during the pandemic itself. But at the time when you were dealing with this, there were step-down facilities or designated settings in place. In your view, ought those to have been in place from the very outset of the pandemic?
You mean before the pandemic started?
No, in response to the pandemic, at the very outset of the pandemic, when the discharge policy was instituted in March of 2020.
Obviously I wasn't there in the department then. I was a backbench member of Parliament, so my access to information was very limited. So I would hesitate to say one way or the other on that, because I wasn't there. I don't have the information at the time, and it wasn't. So I don't want to second guess the decisions that were made at the time, because I don't have that information.
Put it in a slightly different way then, but looking to the future. Is that something that would be desirable, to have some form of step-down or designated settings policy in place prior to discharge?
Yes.
Now if I can turn to perhaps one of the levers that was in place during the pandemic or instituted, and that's vaccination as a condition of deployment.
Yeah.
The regulations initially in relation to those working or volunteering in a CQC registered care home were laid prior to your appointment as Secretary of State, as I understand it.
Yeah.
And so the policy work that had already been undertaken. But notwithstanding that policy was in place effectively throughout your tenure.
Yes.
Or certainly until it was revoked in March of 2022.
Yeah.
Just dealing with that, you were quite heavily involved regardless in relation to consultation and how that would work in practice, because, of course, it was going to come into force in November of 2021. So we're talking directly prior to the Omicron period, if I can put it in that way.
That's right.
And in relation to the impact assessments in relation to those produced an estimate of around 7% of the adult social care workforce within care homes as effectively being affected in terms of that they would not undertake the vaccination. Do you recall that?
Yes.
Fairly significant proportion, around 40,000 workers was the estimate in terms of the impact assessments before you. And indeed, you record within your witness statement at paragraph 169 that making vaccination a condition of employment was likely to have a significant impact on staffing in the short to medium term.
Yeah.
Notwithstanding that, the decision was taken to proceed with the policy.
Yes.
And subsequently, quite separately to that, a consultation was undertaken in relation to healthcare professionals in the NHS, and then potentially for further rollout across wider adult social care settings.
Yeah.
So we had effectively two different policies, one for adult social care staff within care homes,
Yeah.
and a separate situation where consultation was being undertaken, but that policy was not in place for those individuals. Is that right?
Yeah, what's called VCOD, that was, I mean, the policy began before I became Secretary of State, certainly with respect to social care workers in care homes. And so I believe I'm right in saying that the regulations for that had already gone to Parliament. I was aware of the policy, of course, as a Member of Parliament, but was not a minister at that time. When I became the Secretary of State for Health, I inherited both that existing policy for VCOD for social care workers in care homes, and then, as you say, the policy was eventually, under my leadership, extended to include not just NHS workers, but also care workers in all other settings, including domiciliary care settings.
Indeed. And just dealing with that separation for a moment, or the in terms of the staff, you will no doubt be aware there was significant discontent over the fact that it was mandated for adult social care staff within care homes, but not for those, for example, working with other vulnerable people within hospitals.
Yeah.
And certainly some individuals had the perception, at the very least, of a lack of parity as between the adult social care system and the NHS, with feelings of stigmatisation. To what extent do you consider it as acceptable to mandate it for one and not the other?
Well, it wasn't. It was mandated for both.
Let me put it in a different. Well, let me just take a step back and unwind that a little bit. In relation to those individuals working in care homes, it was mandated. It was initially consulted on in relation to rolling it out to the further, wider, broader NHS staff, but that policy was effectively abandoned in 2022. So what we had for a significant period were staff members in care homes subject to this policy, while other people working with similarly vulnerable people were not. That's where the discontent arose, or the perception of unfairness. That's why I'm asking, to what extent do you consider that?
Well, I don't think I entirely follow your chain of thought there, or the reasoning, because that is what you've just said is only true because it's after the events. That's with hindsight. Obviously, at the time, VCOD 1, if I separate sort of VCOD 1 being the sort of initial policy that was brought in, versus VCOD 2, which was the policy I brought in, if you allow me to use that distinction, VCOD 1 was brought in, and soon after the government said its plans were to bring in VCOD 2. So certainly during all of 2021, the sort of the view, I guess, of a social care worker in a care home would have been that, I've been asked to, this policy has been applied to me early, but it is likely now to be applied to others. The point you made about it was eventually withdrawn, and it was only ever applied was because of Omicron and the facts change. So I don't think it would have been possible for someone in 2021 to know that it would have been withdrawn.
But if I can take you back a step, for those individuals working in care homes, they were mandated, and a number effectively lost their jobs as a consequence.
Well, they chose to leave.
I suspect they would not call that necessarily a choice. But taking that to one step back, if I may, those individuals were subject to that policy when others in the NHS were not. That's what I'm asking you about. So there was this discrepancy or disparity in terms of what they were required to do to undertake their roles. I've explained about the perception. I'm asking you to deal with that aspect, and perhaps if I can put it in this way. Do you consider that failure to initially apply VCOD 1, as you've termed it, across the board to include the NHS workforce or other health and care settings would have damaged its credibility as a policy, because you would have had the same types of people delivering the same types of care to vulnerable people?
No, I don't think I do. And mainly because I wasn't there for the decision making around VCOD 1. So I don't know what, for example, what practical considerations there might have been at the time for having the sort of, let's say, if we call it VCOD 1 and 2 at the same time, right? Just having one approach for all workers in NHS and all social care settings. So I just don't know what were the issues that were considered at the time. There could be some very good practical reasons. So I don't want to second guess that. So I don't think it was a issue of unfairness and also.
It's really a question of external perception. So Sajid,
there may have been in some quarters, but if the obviously. People
to the evidence that you heard about transmissibility of Omicron and developing understanding and knowledge, ultimately it was not pursued.
And also the less severity of Omicron, not just transmissibility.
Indeed, transmissibility and severity and vaccination success, in short.
That's right.
It did not evade immunity, vaccine-induced immunity, to the extent that it was perhaps thought that it might in the initial instance.
What? So say that bit again, please.
Omicron, vaccines were effectively far more successful against Omicron than was necessarily thought to be the case in the initial instance.
Yes.
So
sorry, and just to make sure it's clear that also because Omicron was so highly infectious, so for example, something like in the first 8 weeks of Omicron, that accounted for something like a third of all COVID infections during the entire pandemic. That and within a matter of 2 months, we'd switched from 99% of infections being Delta variant to 99% of infections being Omicron, and also people that had been infected by Omicron would have built up some natural immunity, which clearly wasn't the case when VCOD was introduced. So all those factors were taken into account.
Indeed. And my question then is, if the scientific underpinning for the VCOD policy had changed, why was it decided that a further consultation would be embarked upon? The reason I ask that is because, of course, in terms of VCOD 1, care home staff were still having to comply with it. So do you understand what the question that
for VCOD 1, the deadline had passed, had it not?
No, for VCOD 1 was already in place.
Yes, but the deadline for getting vaccinated for those affected had passed.
Yes. Yes, it had. For VCOD 1.
So what I mean is because it had passed, you couldn't sort of really withdraw VCOD 1.
Well, it would have had an impact upon new staff coming into the care home sector.
Yes, but the VCOD 2, the deadline had not passed. And that's why, so the consultation, as I remember it, the consultation on withdrawing VCOD was really focused on VCOD 2. Because the deadline had not passed.
What I would like to do just very briefly is just pull up, if I may, some of the experiences from the inquiries Every Story Matters. That's at 0129. And these are experiences that have been reported to the inquiry. Some care workers were refusing to have the vaccine because of the side effects that were being talked about, and then given the ultimatum, if you don't have the vaccine, you can't work. A registered manager of a care home explained that she resigned from her post because she did not agree with forced vaccinations of her staff, even though she had also had the vaccine in any event herself. Another reported that when the government said all care workers must be vaccinated, half our dedicated workers that had been here for years left. So there are similar themes that are emerging from people that really did feel that they effectively had no choice in that situation. And I just want to continue, if I may, to look at Amara's story from the Every Story Matters, because what you do say in your statement is that it was understood that there would be an impact on those individuals with protected characteristics. Because the majority of the adult social workforce were female, may have disabilities themselves, often have caring responsibilities at home, and often disproportionately from minority ethnic communities with large numbers of migrant workers. Amara gave her account to the inquiry. She's a black Caribbean British woman living in the south west of England. She had worked as a healthcare assistant at a nursing care home for 5 years prior to the pandemic. She had exemplary attendance, and a performance record during her time there. But she was sacked for refusing to have the vaccine due to her personal reservations. She explained she believes in body autonomy and she felt bullied into having something that she didn't want. She further explains that it was a waste of thousands of experienced care staff in a sector that was already chronically understaffed. Most of those staff will never go back into care work for fear of it happening again in the future, and she certainly did not go back into care work. So here, what you see is the loss of experienced, excellent staff, never to return. Are there any lessons to be learned from these experiences, says Sajid?
I mean, yes, there will be lessons to be learned, of course, because this pandemic, nothing like this had happened in living memory. And so, therefore, for everyone involved, those affected, those making policy, this was sort of new policy, new ground, and I think there were always lessons to be learned. But I think that in learning those lessons, we mustn't move away from what was the central objective of VCOD, is that, thanks to medical science and all those that worked on the vaccine, that there was quite quickly an effective vaccine for COVID-19 that was deemed safe by the medical authorities, the independent regulators in the UK, and most of the respected regulators around the world, by scientists and many others. So the facts of the vaccine were that it worked and it was safe. And therefore we knew it's safe not just to sort of prevent an individual catching the infection, but also spreading the infection. I think with the Delta variant, there were the studies that certainly the information I'd been given that it was somewhere between 65 and 80% effective, depending on which vaccine you took, in spreading infection. And the purpose, therefore, of VCOD was to protect vulnerable people. That includes not just those in the NHS settings, but in case, so we talk about social care, let's talk about people in either domiciliary care or in care homes. Elderly people were more vulnerable to the virus, and although they had vaccinated to a large extent themselves, very high uptake, which was great, the workers there was risk from exposure from the workers, and that was the purpose, was to protect vulnerable people. And a balance had to be found between the sort of thinking about the workforce and what were the concerns of some members of the workforce versus protecting the vulnerable people. And ultimately, the balance was, with the prior to Omicron, was that this is the right measure, albeit it will lead to some people leaving, and so it will exacerbate some workforce pressures, as you mentioned and as I've said earlier. But it was still the right balance to be found. Now, turning to, you mentioned an individual, Amara, and there'll be others like her, I am sure. And I'm sure they were very valued and important members of the social care workforce. And it's sad to see people like that leaving. But I hope that individuals like that, maybe even now, might reflect that at the end of the day, the government's job, as I said, there's no perfection here. It had to strike the right balance between protecting vulnerable people and the demands of some parts of the workforce. And I think the right balance was struck in that case. There were some people, and you mentioned people from ethnic minority communities, for example, having in general a lower uptake of the vaccine than other members of the population, and that was a fact. I mean, that was the case, and there's a huge amount of work was done in terms of education, reach out and stuff. So there was a fund to support social care sort of employers and local councils to try and get more information and detail out. But ultimately, if people are not convinced the vaccine is safe, I mean, I believe in body autonomy as well. I think most people would. No one should be forced to take anything. But if they choose to work in a setting that is looking after vulnerable people, and it is deemed that the best way to protect those vulnerable people is by taking a vaccine, then they have a choice. They either take the vaccine or they don't take the vaccine. Their bodily autonomy is totally protected. It might cost them their job, but it was the right balance in protecting those vulnerable people. So ultimately, I think the lesson learned is, whilst it can probably be improved, by focusing on some of the detail more, I think it was the right policy for the right time. And should the country face a similar situation again, I would certainly recommend the then government to consider it strongly all over again.
Thank you. I now want to move on, if I may, to the winter planning for 2021 to 22.
Yeah.
And if I can just call up INQ 00346672, it's a copy of messages between you and Helen Whately, the former Minister for Social Care.
Yeah.
And in relation to those, what she sets out, and it's on page 0002. If I can just go to the next page, thank you. On the 9th of December of 2021, looking at 19/27/21, so 7:30 in the evening, she provides you with some reflections based on her experiences with dealing with Delta, so the wave 2 that we've already touched upon. And what she says is, if you can keep on allowing visiting, but with testing, that would be much better for mental health, for residents and relatives. Frequent staff testing being vital. Regular minister-led calls with stakeholders to hear from the coalface. She explains that staffing would be her biggest worry, and her experience with Delta showed it was very hard to keep the infections out of care homes. In terms of those reflections, are those ones that resonate with you?
Yes.
Moving on to Omicron then, if I may.
Yeah.
The Cabinet Office commissioned a departmental paper as part of its work with the Covid-19 task force for DHSC contingency planning for risks from Omicron. Omicron being seen to pose a significant threat at that time.
Yes.
I want to just pick up on one aspect, and that relates to testing, if I may. If I could call up INQ 00006779, again, page 2, paragraph 7. That's fine. And that identified, approximately halfway down the page, they carried out a number of red team exercises. They identified that testing in domiciliary care was an area for attention. And following discussions at the Adult Social Care subgroup of SAGE on the 17th of December, they were urgently considering the merits of aligning the testing regime for domiciliary care staff with that of care home staff, and then also looking at testing capacity. So, as we can see here, the testing regimes were different. Why was aligning those not considered earlier? Do you know?
I don't know.
Don't know. Moving then to workforce challenges in relation to Omicron, as we've touched upon, during that period the challenges became acute. But we see effectively at that period a reflection, a move to a more local management of risk. And you've touched upon that already and why that would be in relation to local authorities. And contingency plans that were in place, the responsibility on those was for local authorities, is that right?
Yes, I think that's correct.
And just touching on those contingency plans, one of the most significant issues in the first wave at the outset of the pandemic all the way back in early 2020 were the adequacy of local authority contingency plans. You may recall Helen Whately's evidence in relation to that, seeing the plans and those being inadequate. Can I ask you, please, to look at INQ 000576-530, that's page 5. And this concerns the contingency planning that is in place. It's a paper that's being effectively sent to you for sign-off. These are the discussions that are taking place between your private secretary and others within the department.
Yeah.
And it deals with a request about halfway down, can we quality assure QA all contingency plans? And if we go further down the page, I think it's 0005. We see here a response that states, the one point that I've not reflected is the suggestion that central government should look to quality assure the contingency plans of all local authorities. As having discussed with colleagues, we think this will take too long. That's the first reason given. Secondly, is unlikely to add much value because of the distance from the centre to local government. But also, I'd just like you to concentrate on this one, and would transfer risk to the centre if we are seen to have provided endorsement. Is that a legitimate concern, bearing in mind the issues that were in place at the outset of the pandemic?
Reflecting on this, as you raise it, I can see the issue and why it's raised. Your question is it a legitimate concern? I think it's weak. I think it's a weak concern.
So
I think the other points that are mentioned here about it's particularly about timing, as in being. This was a time of Omicron. It was obviously the whole pandemic was a crisis, but I remember at this time, I think this was mid-December or something. It was a particularly high point in the crisis because the focus was very much on boosters and testing and other protections. So I could see that point being much more important about would there practically be time to.
Of course, but that's not what I'm asking about.
Yes, no, but I think the point you asked about, which is transferring risk to the centre, I think that's weak.
And I'm asking, is it acceptable? Is that an acceptable and valid concern of the centre that it would?
I think based on
assume the risk.
I think based on what I've seen here, the documents I looked again at recently in my memory, I do not think it's a valid concern.
Now, a number of actions were taken throughout that period to try to alleviate the pressures that were, as we've already discussed, acute within the sector. There was an ADAS survey that was undertaken between the 24th of December 2021 and the 5th of January 2022.
Yeah.
And out of those local authorities, 94 of them reported that they were managing their contingency actions, but they were forced to implement actions that they found unacceptable. And 49 of those councils were taking at least one measure to prioritise care that the directors regarded as least acceptable. For example, prioritising life-sustaining care over support to get out of bed. They were being unable to take reviews of risk, or leaving those with dementia, learning disabilities or poor mental health isolated or alone for longer periods of time. A number of issues were to be escalated to the government about the fact that there were short-term fixes, they weren't translating to the ground, you had a tired and stressed workforce, bringing home the reality of riding out Omicron, and it was having a serious impact on that health. Were those concerns escalated to you?
I don't particularly remember the ADAS survey, but I think those types of issues and about prioritising care, for example, about what local authorities might think is sort of unacceptable decisions from their point of view to take. Those kind of concerns were often articulated to me, but also obviously the social care minister, who I should mention, obviously I think you know this, but for the record, that I was the Secretary of State overseeing the entire department. There was a dedicated social care minister,
indeed,
throughout my time, and she.
We have a statement from her.
Yeah, and she would be dealing with naturally a lot more issues pertaining to social care than I would be dealing with directly.
I now want to move, if I may, to the end period that we're concerned with and the strategy for living with COVID.
Yeah.
So we're talking about effectively March of 2022 onwards. And there was some to and froing between your department and Treasury in terms of what was going to remain in place and what provisions were not in relation to adult social care and the like.
Yeah.
More broadly, free asymptomatic testing for the public was brought to an end, albeit importantly, symptom-free testing remained for social care staff. In making those decisions, the impact assessment set out that those with protected characteristics or were overrepresented would face higher clinical risks and would be most significantly impacted by the policy. Can I ask you about this, the position of unpaid carers? Were unpaid carers considered when the decisions were taken to cease the provision of asymptomatic testing?
Yes. I mean, so first, unpaid carers, over 5 million unpaid carers. I think, as I alluded to earlier, had ministerial responsibility broadly for the sector even before Health Secretary. I've known for a long time do a super important, hugely vital job. Mostly they'll be looking after their loved ones. And were they considered? Yes, in general, in decision making, absolutely. I think specifically, I think you're referring to the set of decisions in the living with COVID and testing and what was available. I would, at the time, I recall, I would have liked to see more tests, free tests being made available for unpaid carers, including asymptomatic testing, of course. And it's something I had requested and wanted funding for, but I was unable to secure.
Can I just now turn to a topic that runs throughout this period, and that's in relation to efforts to restrict staff movement.
Yeah.
We've heard evidence in relation to that being an important infection prevention control measure.
Yeah.
But that it was challenging, and it became clear that mandating such a policy would not work owing to concerns about the insufficient numbers within the workforce and the practical issue of loss of income for those workers in a precarious sector with insufficient staff and fragility. There's further been evidence that those funds that were designed to enable staff members to isolate without losing pay or restrict movement did not always reach those recipients. Do you agree, or do you have a view on effectively recommendations in regard to the future and future learning, that these are areas that pandemic planning must explicitly address?
Yeah, I think this is an area of future learning. I mean, I think that I completely understand in terms of protecting vulnerable people, the need to look at staff movement. But I think it's fair to say, especially at the start of the pandemic, that because these kinds of issues had not been sort of thought about in advance of the pandemic, there was no sort of pre-planning, so to speak. I think there will be lessons to learn from that.
And were mandatory restrictions to be considered, do you agree that they should not be introduced until effective mechanisms for full sick pay, for example, for self-isolation, or financial compensation for staff who are unable to work between locations?
I think those things should be considered. I just hesitate to say they must not be introduced before, because it's just that we don't. None of us know the nature of future crisis. I think they should be considered.
Indeed. Now, throughout this period, there was and still is a widely held belief that the NHS was prioritised over adult social care, with adult social care being the Cinderella service. What are your views on that from your time in post? Just briefly.
I think that was absolutely not the case. I mean, obviously, I can't speak for activity before I was Secretary of State, but certainly in my time as Secretary of State, in terms of adult social care, there's all the things that we've talked about that were specific to the pandemic, and that was my most immediate focus, naturally. But I also published as I referred to earlier, the Adult Social Care Reform White Paper. It was a very detailed set of reforms for the future, thinking in much detail about the sector, how to improve it, particularly around issues around workforce and payment and long-term funding. I also published the Adult Social Care Integration White Paper, I think in early 2022. I made amendments to the Health and Social Care Act that were many around adult social care, because they were amendments. They were not originally envisaged when that act was introduced to Parliament. And also there were other things that I did that, for me, I was thinking a lot about adult social care and improving it, even though there were health components as well. So the work that I did on the 10-year dementia plan, for example, because I felt that if we could deal with dementia better, then it would help older residents whether in care homes or domiciliary care, because we have a better approach. So it's a sector I spent a lot of time thinking about and doing something about.
Thank you. Can I now ask you about domiciliary care? You've mentioned it there, and there are only really passing references in your statement to it. Is that indicative of a lack of consideration in relation to domiciliary care compared to both the NHS and care homes, with the understandable focus, as it were, was in the immediate start of the pandemic? No,
it's not.
If I can then turn to more general considerations with regard to the sector.
Yeah.
It's been posited that the register of adult social care workers in England would assist in a pandemic, both those working in care homes, domiciliary care, and also, on the converse, those individuals who live in care homes and receive domiciliary care. Do you consider that would be a useful tool to have?
In general, yes, I do. I do, because I think I might be right in saying I think that England is the only part of the UK nations that don't have one, but I think that in terms of professionalism, more confidence in the system, I think it sounds like a sensible thing to look at.
And finally, if I may, just turning to your recommendations, you very helpfully set out your lessons learned and recommendations at the end of your witness statement.
Yeah.
You explain that you consider the adult social care model to be broken.
Yeah.
And you explain that in your mind, this part of the solution is assisting more people to look after their own relatives where possible.
Yeah.
What do you mean by assisting people to look after their relatives, and how would it work in practice?
I think this is, again, if I may just draw your attention back to the Adult Social Care Reform White Paper and some of the sort of comments and speeches I made around that time, is that notwithstanding the huge amount of work done by unpaid carers already, and recognising all that they do, I think that more should be, the state should be looking at more ways to try and support that. And I wasn't, at the time I suggested that in the Reform White Paper, I wasn't entirely sure what the exact mechanisms are. I think there are other countries we can learn from. I think I'm right in saying that I allocate something like £25 million of funding to help try and support that, and suggest that there should be workshops and other discussions with representative groups to look at what can be done. So it was something that I think is long overdue in terms of focus, but I had not got round in my tenure in that seat to look at more specific examples.
I think, I'm sorry to interrupt. I have to leave that there, Ms. Cecil, please.
Indeed. Those are all the questions I have, my lady. So, Sajid, if you remain there will be some more for you.
Thank you.
Ms. Morris.
Thank you, my lady. So, Sajid, I asked questions on behalf of the COVID bereaved Families for Justice UK.
Yeah.
And just one topic for further exploration, please. And that's regarding hospital discharge.
Yeah.
You said to Ms Cecil this morning, in respect of delayed discharge, that it was a significant issue for the DHSC both before and during the pandemic.
Yes.
In your statement, you mentioned a number of initiatives around that: a discharge task force, a red team meeting, winter planning meeting in October 2021, a deep dive after that, and then a step-down plan that you've also touched upon.
Yeah.
You also said that the NHSE were working with local authorities and integrated care boards.
Yeah.
And this morning you were keen to highlight the work that the NHS was doing with the local authorities. But you haven't mentioned either this morning or in your statement what arrangements were in place to engage with the adult social care sector itself, whether that's in the care homes or the carers. So I wanted to ask you, what was that engagement when you were Secretary of State with the actual sector itself, so beneath the local authority level?
Yeah, and so thank you. And so, as you highlight, delayed discharge has been an ongoing issue, a challenge, obviously made much worse and acute during the pandemic. In terms of if you talk about my personal engagement with the sector, it was at various levels. It was, so at one level, it was actually visiting care homes, providers of domiciliary care, meeting local authority leaders and others working in the sector to sort of hear from them direct, to see for myself some of the issues, things that were working, things that were not working well. It was still, I think I must have met with on probably more than one occasion, but a number of occasions with some of the leaders of the sector, different various organisations that represent different aspects of adult social care.
Around this topic specifically, can I ask?
I would have had discussions around this topic specifically, yes, as well. I think generally when I'd have a meeting with a representative of the sector, they'd cover I think this topic would definitely have come up because it was such an important part of the work that they were looking at.
Well, that's why I posed the question, because I want to ask you whether you consider that it was sufficient engagement with the sector itself, particularly having regard to the grave concerns that had been raised around the discharge policy from March 2020. So before your time, but looking at the engagement you had, do you think it addressed some of the concerns that had predated?
My feeling is that if you talk about my engagement, I think it was sufficient. Keeping in mind that my responsibilities were included adult social care in this issue, of course, and it was a very important issue, but there were very wide-ranging responsibilities. I was also trying to deal with the emergency of Omicron as well, in particular for a significant part of my period. But also, as I alluded to earlier, one way to make sure that there's a government, that there's enough, there's more engagement than just the Secretary of State, is why specifically there is a social care minister that would be the person, as it was in this case, that would be having a lot more engagement than I would, as well as other ministers in government generally, but especially the social care minister.
Thank you very much. Those are my
and officials, of course, who have engagement.
Thank you very much.
Thank you.
Thank you, Ms. Morris. Ms. Weston.
Thank you, my lady. I'm asking questions on behalf of the Frontline Health Workers Group. Our questions concern the impact of the pandemic on migrant care workers.
Yeah.
In your statement for this module, with reference to the impact on those with protected characteristics or vulnerabilities, you state, for everyone's reference, it's paragraph 44 of the statement.
Yeah.
Firstly, that you were aware of the PHE June 2020 study, Disparities in Risks and Outcomes. My lady, that report is at 399820. There's no need to turn it up, which demonstrated the disproportionate impact of the pandemic as a result of health inequalities.
Yeah.
Secondly, you note that you had an interest in the subject and were looking to take practical action. Now, that study concludes, page 4, my lady, that 2 of the most at-risk categories were specifically migrants and also social care workers.
Yeah.
Do you agree that it follows that it would have been obvious, therefore, that migrant care workers were at particular risk?
Sorry, just to clarify, do you mean a particular risk of contracting COVID, of what?
Well, they were at the particular risk of the poorer outcomes identified in the study. That's because they fell into 2 categories which would attract a degree of risk. Not that they would necessarily have worse outcomes, but that they were...
I think I would agree that migrant workers working in social care, that there were certainly considerations particular to that group that should, and I think would have been taken into account. So, for example, I think I'm right in saying that migrant workers were probably less likely, we thought they were less likely to take the vaccine and less likely to be vaccinated. And so we would take that into account. And obviously then the fact that if there are migrant workers working in social care, other factors around social care. So we would take all that into account. It's just that I wasn't entirely sure what you mean by that they're at more risk. I think I would say that that would certainly be taken in those facts that you've mentioned, those issues that you mentioned would be taken into account.
Well, there were risk factors which affected that group of people. There were risk factors by reason of them being migrants, due to health inequalities that were referred to in the study, and there were risk factors in relation to their work as social care workers. That's
yes,
right.
And if your question is, would I and would the department as a whole take them into account? Yes, and especially when you mentioned health inequalities. During my time in this job, health inequalities, we've talked about it in previous evidence sessions, is something I did a considerable amount of work on, whether it was health inequalities for migrant workers or people in lower socioeconomic backgrounds or ethnic minorities. There was something I did a considerable amount of work on, which I think shows perhaps the extent to which I took issues like that into account.
Yes. So can you help the inquiry with what focused consideration you gave to reducing that risk?
To reducing that risk to that cohort of migrant care workers. I think so one example I would give is that in terms of vaccination, and and especially referring to the VCOD policy we talked about earlier, is making sure that there was enough reach out to members of that community, there was enough engagement, there was support for both local authorities and employers in terms of funding, support and things to reach out and to perhaps, for example, educate on the vaccine, why we have the VCOD policy, why it would make sense in terms of protecting vulnerable people. That kind of engagement was something that we done specifically to try and reduce those risks.
Could you help the inquiry with what was the financial support that you gave that sector?
I don't remember exactly.
Thank you. I'm going to move on, if I may, to domiciliary care.
Yeah.
It's already been pointed out that you make little reference to domiciliary care in your statement by the Council to the inquiry. Had you fully appreciated that workers in domiciliary care are frequently on 0 hours contracts, that they're migrant workers on tied visas, and they're also undocumented workers who may have come to the UK legally, but whose visas have expired, and therefore those groups are less able to challenge conditions. Their ability to challenge conditions is severely limited by that. Was that appreciated by you and your department?
Well, if by appreciation, if you mean was I aware of that, and do I think the department was aware of those the points you just made? Yes.
So, Dr. Townsend, in her witness statement, on behalf of the Home Care Association, explain the connection between those immigration policies and insecurities. In this way, in paragraph 303 of her statement, she said, the prevalence of insecure 0 hours contracts and limited sick pay provision.
I can't see where I've given permission for this question or this reference.
Sorry, yes, it's right. It's just the lead into the question 7 for which
I'm sorry, you've got to be really careful. I'm sorry to stick to what you're allowed, and I'm not going into overall policies like 0 hours contracts that limit what I can do in this inquiry. So. Could you please stick to your question 7, please?
Point taken, my lady. Do you agree that the cohort of care workers to which I just described, the 3 cohort of care workers, were simply ignored by government with wholly foreseeable adverse consequences for transmission?
No.
My lady, those are my questions.
Thank you, Ms. Weston. Next is Miss Beattie, who I think is going to be across the room if she's sitting where she usually does, Sir Sajid.
Okay. Oh, yeah.
Thank you. I ask questions on behalf of disabled people's organisations.
Yeah.
You've told us that you continued with the discharge to assess policy, which had been put in place before you came in, and you saw it as a more person-centred approach in your evidence. During your time as Health Secretary, I think there were 2 reports which raised specific concerns about discharge to assess. In October 2021, the CQC State of Healthcare and Adult Social Care in England report noted concerning evidence that support needs were not being met of people following their discharge. And in December 2021, the Department of Health, your department, published a review by the Social Care Institute for Excellence, which had been commissioned by the department, which again reported that there were unmet needs and concerns about follow-up, particularly for people with complex social care needs. Did you take those reports into consideration in looking at discharge to assess when you were Health Secretary?
Yeah, was that second report the Pearson review?
No, it's by the Social Care Institute for Excellence, commissioned by the department.
Okay. Yes, but I would caveat it just by that as you alluded to, the policy was already in place when I became Secretary of State, and these reports came, although they may have been commissioned before I became Secretary of State, they weren't available until, as you said, I think October, then September.
Well, I think so the CQC annual report came out in October 21, and the Social Care Institute for Excellence report, I think, had been first submitted in draft to the department back in March 21, with a final report in April, but then it was finally published by the department in December. So they're being published during your time as health.
That's right, and what typically would have those reports, even before they're published, it might be that the officials have had some interaction with the people working on the reports and things, just to sort of, if there's anything acute, especially that needs immediate attention, and it would have been brought to my attention sort of at the time and indirectly, rather than me waiting for the report and actually landing on my desk and going through it. And so it would, if your question is, would the findings of these reports have been taken into account, they would have.
Did you take them into account?
Yes, but my only caveat is that it wouldn't have been, I would have actually received the report on my desk and I would have read every word in the actual report. It would have gone through my officials and they would have picked out the most important bits, and this would have been an important area. As I remember, I think, for example, the CQC report, which obviously is the first one you mentioned, a very important report, I think they generally supported the discharge to assess policy as the right policy in general. But what they picked up on, and you've touched on, is that there are certain aspects of it that could be improved.
Are you aware of any auditing of discharge to assess cases in light of what these reports were telling you?
I'm not aware, no.
Thank you, Melanie.
Thank you.
And next, is it Mr. Strong? We also will be across the room.
Yeah. And you're just waiting for the microphone to come on. Thank you. So Sajid, I represent John's campaign, Patients Association and Care Rights UK. So there's just one area. You recognise at paragraph 42 of your statement that people the adult social care sector exists to serve should be at the core of all decision making. But many of those who represent people drawing on care consider that their views were not adequately listened to by the government. Do you accept that more should have been done by government to ensure the views of these people were taken into account in decision making?
Look, I'm very much in favour of those that are affected by government policy, that their views are taken into account in whatever, and there are a number of ways to try and do that, whether it's through consultations, direct meetings, obviously numerous ways to do that. And I've always been in favour of that throughout my time in government. Your question was more specific, I think, was could more have been done? Well, first, I can't speak to the first part of the pandemic because I wasn't there, and I'm not going to second guess the decisions that were made then. So could I have done more during my time to engage more? It'd be hard to see how. What I mean by that is that, as I alluded to, my responsibilities were quite were broader than adult social care was a very important part of it, of course, but they were much broader. I was dealing with a national emergency, and especially during the Omicron period, and I was pretty much working every hour that there was available to work. So, I mentioned earlier about meeting people in domiciliary care settings, in care home settings, meeting stakeholders, and in terms of both employers and local councils and people actually receiving care, and also I had the support of other ministers. So, but I want to be very accurate in my answer to you. You asked me, could we done more, even more? It's hard to see because something would have to give. If I spent more time with the adult social care sector and listening to people's views and concerns, which are very legitimate and I want to hear them, I would probably have to spend less time somewhere else. And if I did that, I'd probably have someone standing in front of me saying, why didn't you spend more time with us? And why did you spend even more time with adult social care people? So it's a very difficult balance, and I think I got the right balance.
How about helping in terms of recommendations for the future? Is there anything specific, any specific mechanism which you think might help to ensure that those views are filtered up in an easy way for you to quickly understand in a situation of crisis like this?
No, I think it's a very good question, and I think there probably are in the. I alluded to earlier that the sector, adult social care, is very fragmented for the reasons that I've said. And that fragmentation does, I think, just make it that much harder to sort of, for the centre to sort of get views and those views to be sort of, put together and see if there's sort of, for example, themes emerging from those views. So I think probably there is something that can be done, and maybe I wouldn't want to sort of just sort of come up with ideas on the spot now, but some kind of structure where people receiving care or their families, their loved ones could input in a structured way, and then themes could be identified, and then the ministers have some kind of responsibility to maybe at a regular period, annually or something, to respond to that.
Thank you very much.
Thank you, Mr. Straw. And finally, not finally, Mr. Boyle. I'm not sure where Mr. Boyle's sitting.
Sajid. I can see him. Thank you.
Thank you, my lady. Good afternoon, Mr. Sajid. I ask questions on behalf of the Royal College of Nursing.
Yeah.
In your witness statement, you helpfully describe how you met with the Chief Medical Officer roughly three or four times per week.
Yeah.
Whereas you met with the Chief Nursing Officer 2 or 3 times in total, by which we understand across the piece that we're looking at of your reign, June 21 to June 2022. Yeah. Given the importance of nursing staff to healthcare response, do you feel it would have been helpful to meet the Chief Nursing Officer more often to discuss critical safety issues?
I think in one respect it might have been more helpful, but the previous question, I talked about the trade-off in my time. I think something else would have had to give. So someone else I would be meeting a lot less, and maybe so I had to you think about my time in a holistic way, and so because of that, and knowing that the views and the work done by the Chief Nursing Officer is so important, the way I try to deal with it is, as well as my own meetings, is to make sure that the views, the concerns of the Chief Nursing Officer are taken into account, not just through meeting me, because sometimes that could be too late, because it could be some things in the diary, but it's 2-3 weeks away, because that's just the way the diary is. And so there had to be, and there was, direct contact between the officer and her office and my office and other parts of the department, and also other ministers would meet with the Chief Nursing Officer, not just the social care minister, but maybe other ministers. And I think taken together, the interaction with my department officials, with junior ministers, and with myself, I think that was the right balance.
Thank you very much.
Thank you, Mr. Boyle. And now, finally, Ms. Peacock.
Good afternoon. I'm here on behalf of the Trades Union Congress.
Yeah.
My question pertains to vaccine confidence in social care workers. The inquiry has received some individual accounts from social care workers which recall receiving little information or support regarding vaccination against COVID-19. And similarly, in a recent survey of over 1,600 social care workers, 58% of respondents said that they did not feel they were given enough information and support by their employers regarding the vaccines. Do you agree that some work can be done, rather, in advance of any future pandemic to improve lines of communication with the workforce and to ensure that all workers can, if necessary, be provided with the information and support required to build vaccine confidence?
Yes.
You've mentioned, I think, in your evidence before that one feature of the social care workforce that was a challenge in comparison to the NHS is that it wasn't a centralised body. Do you consider that that was a feature in the difficulties of the information you've described today reaching care workers? There wasn't a centralised oversight body?
I'm not sure, because, and I say that because the NHS, for example, is a centralised body, and I know that some of the concerns you articulated on behalf of social care workers have also come from the health sector. So I'm not sure if that was a important factor, but I think it's worth looking at.
If I may just clarify, I think you said in Module 4 that it was easier to address hesitancy because of that structure in the NHS being an a centralised state body, you said. So is it fair to say that a mechanism that can give some centralised deployment of information and support to care workers in relation to vaccines or therapeutics as it may be in a future pandemic?
I think if you're referring to maybe a more sort of central-led way to distribute information and make sure so that it reaches the right people for them to consider and stuff, I think that is worth considering in terms of disseminating information. I think it's worth considering.
Thank you, my lady.
Very much,
Thank you.
Peacock. So, Sajid, that completes the questions we have for you. I think I can say for the inquiry.
Really? What if I want to come back?
No, you can't come back unless I call you.
All right.
So
Thank you very much.
Thank you very much.
Thank you, my lady. Thank you.
Okay, right. I shall return at 2:05.
further notice. There have been cancellations across the board today. More than 20 flights were due to come in and out of the airport, and we've actually seen plenty of people turn up who had no idea that their flights had been cancelled, including one family who'd come from Portsmouth about 2 hours away. Eyewitnesses said that they saw the pilots waving to people, including children, before they took off, but they were only in the air for a matter of seconds before hitting the ground. At the moment, we don't have any indication about what caused this crash, and again, we still don't know the identities of the four who were flying. We went with it pretty hard.
Yeah? What did Alex say?
She called them and basically and they were like, well, don't attribute the response to that into why. It's like we need to know each credible
Phone traffic then. Yeah. Oh yeah, go on. Hello, traffic. It's Brad Vincent here. Hi. I've got a piece of camera to feed from Grayson Road 33. They were up on Nationals Live. So I just plugged straight into their live. Don't know what call they were given. Hold on. 3-1. What? 3-1. 3-1. Hold on. It was on 3-1. Okay. Yep. It's still up. South End crash, Easter camera, PTC.
Thank you, mate. Thank you.
Caf Opata. minutes with the statutory, so can we call back when it's finished? Yeah? Take it to the bike.
They're not wrong. No, yeah, they are. It's just that, because I've done. There's no way to say
Still feeding now. We'll have 5 minutes to go, so. Do we know where this press conference is?
they sent it to the main entrance.
Over there.
We're sending the press live.
Are you sending it in live? Or I'm going to do cutaways in? Yeah.
By the time you go back in. Might get back.
see those privets here are residents. That's a lot more south end. Yeah, that's it. All cleared? Thank you very much. Cheers. Bye. That's done. We did 2 Italian girls who showed up at the airport. The monitors are just beaming heat down onto them.
Has to be exactly 17 degrees, or like rubber ball literally walking up and straight back out again. So like they came in with a temperature, checked it, and then they were like, you guys, once we set up, they're like, you guys all go out because you will like generate heat, like all in the room. So we all had to like come out. And there's just like, I think it was just like mate who like follows him, comes with him everywhere, and he's like this kind of future parent, bigger guy, and he just came in and like sat on the floor like underneath the camera. impressed he was being told like 5 years ago that they need this specific work, and it's stayed on the information in like 5 years later. So every single thing they ever go to, they're like, you need to make sure you bring a ring on. You just bring one and have it in case there, and it's like, you've got a ring, like, yep, there it is, like, and then don't use it. And it did get like that. It was like almost like you were institutionalized into just doing that all the time. It became like canonical, go to an office. Basically go to a different hotel and do the same thing. Two, 3 times a week. I mean, sometimes you get free food and like,
Setting up over there, we will go. Why? You think all the slide, straight down the lenses and every camera?
There's like loads of do stuff like that, like leave it right to the last minute. So like we did one with Rachel Reeves, and for about an hour I was like, where are we going to be doing this? Like sit down, we've got 2 cameras and set up with like lights, blah blah blah. And like, we'll let you know, don't worry, we'll give you plenty of time. Just get out to where it's going to be. And then we got up just there, and she was doing a walk to speak to people like that. And then they were like, right, we've got 5 minutes, and we're just going to do it here. And I was like, why here? Like that's the background's terrible. You're like almost having to like argue like, with them. And they're like, no, it's here. And I'm like, well, why? Who's decided that? Like what? And they basically just made it up on the spot type thing. And we don't, yeah, and they just don't.
I went to one in like a gym here, but very and we were actually going on a rave, and then press up was like, oh, just jump in the car with me, just drove us the wrong address. All of the broadcasters went to the wrong address. All of the papers went to this amazing array of brilliant, so someone jumped in the ocean, we driven us into the other place. Just like kind of made a joke about it. We now don't know.
That's not funny. That's no reason to fuck up.
And then there was like a walk along with the police, politicians, but we just like had them in twos, like none of the and we had to like step in and be like, can you walk around? Like just paint. Particularly after we've been like, we need something.
Who knows, yeah, isn't it? So they just kind of make it up as they go along.
Nice big.
They're also young, like, that's right. It's like an election, like we should see it. No, that is a sweeping statement, actually. It's not everyone your age. Look, you're young. Yeah.
One with the immigration. This one address is a supermarket. Wandering up again. It had to be those two guys running out of the store. Would it? Running down the road. Oh fuck!
You didn't see that, right? You didn't see that. Yeah, I had a similar one actually. There's the workforce. It was like this Vietnamese flat in Southampton. But it was like a bug shop, and the rear access they had like boarded up, so it was like basically no one could figure out how they got in or out of this flat at all. So this guy was like walking around for about half an hour trying to figure out where the door was. So like not very subtle. They could have got out multiple. Yeah. They literally just like, and he was like a big guy on his own. He was the only guy in like all the gear and everything like that. And then they decided to like knock this door that they boarded up, and it took this guy, I kid you not, probably about 40 minutes to like it was literally just, it was like taking breaks and stuff, right? They'd sit down for like 5 minutes. Yeah, it was surprising. Yeah, after 2 hours of like floating around that property.
I went on one with Javid called Molecules, where they do that. You did the brief beforehand, and they go, we've got really good intel on this, and this guy's here, this guy's there, this guy. Amazing. And each one of them, it was like we went to one, and then crashed in the door. The person asked me, you arrested me yesterday. And the next one after that was like, he hasn't lived here for years.
Yeah, we've got intelligence.
Yeah. We can imagine it. Bye.
Having Catherine back then, she's got...
This is nothing to do here. It's not, you know, we've got...
It's been a rapid from back.
Yeah, rapid from back there. We've got a couple of boxes to do. One box is here. We've got one with two Italian girls who didn't know the flight was cancelled. And then this flame smoke, but it's moving up. Yeah, and he's done his piece of camera, which is now blown out the wall, or the end bit. So he had a pause. Yeah, he had a pause on it, so he can just cut it there. But no, it moved along from where that chimney is. It moved along to there. It keeps on moving up. Might be a ship on fire.
Yeah, I mean, you can see it.
Yeah. What time is this press? 3. This end.
This end would veered off to the left. So I think it would be like over.
Yeah.
That. I mean, I can see.
Yeah, you might be able to get this.
Yeah, I'll give you a call if anything.
Yeah, I do. Thanks, man.
Thank
So apparently it's going to be here.
I saw here.
Yeah. Don't know if there's going to be any seats or anything. Yeah, I know. Oh God. Yeah, that was intense.
Just on the phone, so that's all going to be outside now.
Oh, it's going to be outside, is it? Okay. Fine. What, like, where exactly?
So they're on their way around shortly, so they'll be able to...
That is gorgeous. Okay, thank you. Interesting. Outside it's going to be. Say that again? Yeah.
I reckon it'll be on the grass somewhere.
Yeah, I think that makes sense to have the separate.
Yeah.
So we post up and say, come to us.
Yeah, it doesn't seem like they've got
They've told us outside instead.
Oh, really? In, out, in, out.
Can we find a shadowy place then?
Is this for the press conference?
Yeah.
Is this what they said? This location?
No,
They just
just
said
said
outside. They said wait here
I think
until.
somewhere
Maybe we can
on the
put them
grass
standing
might make sense if there's going to be a
in
big
the shade,
crowd.
just move in
Shade.
closer.
This guy had no clue. He said I could do interviews inside the building.
Yeah, it's more cooler. You want to go in and ask him again and see what he's
Can we do it here so we've got south end in the
Yeah,
background?
yeah. We'll just have to stop any passerbys from going across.
Well, I don't think there will be many.
Well, there's been a few so far. You don't even the mic say
They have changed the name again. So they're all in a rush.
We'd like to do it in the shade if we could.
Yeah. Will we be able to do it in the shade?
I can't take 10 opinions. Sorry. Bear with me. There is somebody coming who's going to state where they want it to go.
You could be waiting an hour.
Sorry, yeah.
Say that again? Oh, I know. Why we have to use white? I've got no idea. I do my best, but what can you do?
They're going to change it so that it's going to be white now.
So, are you hearing it clearly? If I'm talking from here, is that clear enough? Yeah. Okay. Fine. Lovely. Okay, that'll do then.
Yeah. How's the sound, Ben? Has it been sound okay? Yeah, clean. Podiums and stuff like that. I'm now stood in front of it, but yes. Lovely. Thanks so much. Cheers.
Sorry. I'm just interfering with your setup.